In this module, we're discussing the different interventions you can use on an isokinetic dynamometer. There's applications available on a machine all the way from day one post-op all the way through return to sports. Let's start off at the beginning of the rehab, using passive motion on the dynamometer. In this first position, we're looking at passive motion for the knee in the prone position. And this is great for any hamstring strains or anybody that needs CPM in the prone position to help out with that terminal knee extension, similar to a prone hang. Now, the way that CPM works is if you're looking at a joint and if a joint is swollen, as that knee or the shoulder or the ankle, as it moves back and forth through the open and closed pack positions, that's going to create a pressure gradient inside that joint. And it increases and decreases with the motion. So when you do that, that creates a pumping mechanism that's going to pump out any extra swelling or blood that's inside that joint. Next, you can see us working CPM for the knee and sitting, very similar to what we saw in the prone position. Now, all your other tissues are going to be moved back and forth. It's going to reduce any scar tissue formation that's going to occur inside the muscles, the tendons, the ligaments, the retinaculum, and it frees everything up. Another thing that CPM does is it stimulates the mechanoreceptors of the joint and the tendon and the muscle, which is going to reduce and inhibit the nociception and make your pain less. And anybody who hasn't seen this gentleman before, that's John Hisamoto. He was my mentor all through my athletic training career and physical therapy career. All right, next we have ankle CPM for dorsiflexion and plantar flexion. This is fantastic for anybody who's had an ankle sprain. This is also a great position for post-op Achilles tendon repairs. Because we have the knee in a flex position, as that ankle goes back and forth, even if you go to the neutral position, it's not going to put a lot of tension through that Achilles tendon. Now, you can also do CPM for the dorsiflexors, plantar flexors with the knee extended, but we don't want to do that initially after Achilles tendon repair. Next, a patient is going to be working CPM for ankle inversion and eversion. Another great, fantastic initial treatment on the machine after an ankle sprain. In this position, we're looking at hip internal and external rotation. This is really good, mostly for some of your older patients who have hip osteoarthritis. But if you have anybody who's recovering from a labrum repair, this is really good to use initially, so long as you stay within the range of motion restrictions. This next position is shoulder flexion and extension in the supine position. Now you can also work this in prone. You can do it in sitting as well. It's a great early technique for an injured shoulder or after a shoulder surgery to mobilize them. The advantage you get using the machine is that you can set the range of motion to a very precise angle to where it does not go beyond that motion. You can also set the speeds. You can set stretches, pauses. You can increase the range as you go. You can decrease the range as you go, all with clicking the mouse. It's very simple. It's very comfortable for the patient. It frees you up as a therapist. So now instead of me mobilizing his shoulder for the next 10 minutes and not being able to go anywhere else or work with any other patients, that frees me up as a clinician to go take care of other tasks. This is CPM for the shoulder, ERIR. Another really good way to increase motion, reduce pain, reduce any apprehension that the patient might have to the machine, reduces muscle spasm and muscle tone. It's a great intervention. And here you can see one of our college pitchers from a few years ago. We had to mobilize his elbow after Tommy John surgery. And this is a great way to do it. Really helps get that extension back quickly and reduces that swelling inside the joint. Now that your patient has good range of motion, their swelling and pain are down, we can start working on stabilizing. And in the machine, we use the isometric mode. And what this does for us is it allows a controlled early contraction and neuromuscular reeducation of the muscles. Now, I'm only going to show you a few positions in this video, but any position that you saw in the range of motion, you can do it as well. Right now, I'm doing an isometric hamstring contraction. I'm holding for 5 seconds, then I get a 10-second rest, and then it changes position. And typically, we go every 10 to 20 degrees of the range of motion. Now, in this video, it's only doing one contraction in each position, then moving. But typically, we do 3 to 5 contractions before it moves. But that makes for a pretty boring video. You can also see on the video that there's a feedback that's given. The harder I pull into that hamstring pad, the higher up my torque bar goes. But there's other ways that we can look at this with the biofeedback that really help with the neuromuscular adaptations. I can put a target on the screen that the patient has to stay within that precise target. Think about early on after an ACL surgery or after a rotator cuff surgery. We're not wanting them to push hard. We're talking 5 to 10 foot-pounds of torque. Very light, but we're just wanting to make those muscles start to wake up and fire under safe, controlled positions. In this video, you can see Chris. He's one of our athletic trainers. He's doing multiple angles for shoulder external rotators. Another great use of isometrics on the machine is for tendinopathy and joint pain patients. We can perform long hold, heavy load isometrics. The advantage of using the machine is we can find out what 80% of their maximal volitional contraction is and have the machine set targets at that amount for them to exercise. And this is great for tendinopathies and joint pain. So now your patient's progressing, they're doing well, they're able to do light contractions, they're feeling better. Now we can start working on strength and control. And we're going to do this first with isokinetic, and then we'll go into isotonic after that. Now, the first type that we're going to perform is a pure isokinetic eccentric unloading. And in this, the machine is going to lift the limb up for the concentric mode, and then the patient has to unload the weight of the limb in the eccentric mode. So she's resting on the pad, and it's going to lift her tibia up. When she gets to the top, she's going to contract her quad, and she's going to lower down the weight of her own leg. Now, she's not pushing into the pad. She's not producing an external force or torque or load. She's just controlling the weight of her own limb down. And we're starting out very slow, 5 degrees per second. Now, in these next few videos that you're going to see, we're going to move through the speed progressions. So this is 5 degrees per second. He's going to push up into the pad on the way down. And we're only working eccentrics. If you go back to earlier when we talked all about eccentric loading and the purposes of it, that's why we're only doing eccentrics early on. In each of these clips, I'm showing you just 1 or 2 repetitions of an entire set that we would perform. We typically would perform between 3 and 6 sets of 10 at each of these speeds, and every week throughout their rehab, the speeds get going faster and faster. We start out at 5 degrees per second, and then 10 degrees per second, and then we progress about 5 degrees per second each week. Now we're getting to some faster speeds. This guy's going 60 degrees per second on this one, and then 80 degrees per second now. and then his next speed will be 100 degrees per second. So we're getting into what we call deceleration training as it gets faster and faster. You should see that each one is increasing in speed. Finally, you have Bradley. I have him set, I think, at 150 degrees per second here, as this is when we're getting into high speeds. Now, as they progress, you can even get into having them do both the concentric and the eccentric portions. Typically, when they get into those that deceleration training, we work the muscle both directions, concentric and eccentric. So for the final video series, we're going to go into isotonics. And isotonics are really good for strengthening, but a big part of it is going to be neuromuscular control combined with the strength training.
Other great uses of isotonics on the machine is for muscular endurance and power training. I love using power training at the end of a patient's plan of care as they're readying for return to sports.
Now, the first thing I'm showing you in this video is using the machine truly as pure isotonics. I set it for 100 foot-pounds of torque, and I'm just pushing up and bringing it back down, just like you would on a normal knee extension machine. And that's not how we use the machine. I did it just to show you what it doesn't show you, because it doesn't give you any good feedback.
Now let me show you a great way of taking advantage of the visual feedback to enhance the exercise.
This application is called pacing bar. And so you set your torque. You can set that for, say, 10 foot-pounds, 20 foot-pounds, 100 foot-pounds, whatever you set it to. But you can also set it to be different amounts of torque in both the concentric and the eccentric. So I can have it be heavier coming down eccentrically than I do going up. On this application, Bradley is controlling that blue line that goes across the screen. He has to pace himself or time his tempo to match that bar that goes up and down. And you can set this to be different speeds. It gives you a score, what percentage of time they're on target in concentric, what percent of time they're on target in the eccentric. I have his just at 10 foot-pounds each direction. Usually when I do this, especially if it's later on, I like to make that eccentric load about 30% heavier. Now, when I first start doing any of these applications, I can actually set it to have no resistance at all. So this is called roadway. The patient controls, again, they're just kicking up or pulling back down, and they have to control it and keep the little dot inside the purple lines or the roadway. And right there is where the patient's dot is. And you can set this roadway to be different shapes. It keeps track of percentage of time that they're in the roadway. And you can set the difficulty to where if they're above 50% on target, that counts as a good rep. If they're below 50% of the target, that counts as a bad rep. Typically, I like to get at least a B. So I'll set it to be an 80% on target. And you can see our patient here, she's working back and forth. Again, I don't have any resistance on it. I believe at this point she was about 8 weeks out of an ACL reconstruction. She was one of our local ballet instructors. Now, I believe on this next one, I purposely had her do a bad rep. So you can see what happens if she's outside of the roadway, the ball turns red, she gets a bad rep. So if you look at the top left, you'll see she got a red dot for that one. Next, we're going to work on some pure proprioception and joint positioning. So in this, the patient controls the dot, and the computer puts a ring or a target on the screen. The patient's job is to get their dot into the target and hold it there, and it changes back and forth as they go. It keeps track of the amount of time that it takes for them to respond and get into the target, and then how long it took for them to actually hold steady in that position as well. This is really good early on to help reestablish neuromuscular education and proprioception, but you can also do this with resistance. Now, one thing you may have noticed in all these videos is that I have the tibial pad, adapter pad, higher up on the tibia in that mid shaft. That allows us to work the quadricep in an open chain without getting any anterior translation of the tibia and not putting any undue stress on the ACL. So that's a way that we can perform open chain exercise and resistance early in the rehab process without the dangers of risking damage to that graft. This next one is called interactive path. And you can see Chris, he's going to do this with his shoulder. This is kind of like a maze. So he's going to control a dot, and the maze is going to go across the screen. And as it goes across, his job is to position his arm, or if it's his ankle or his knee, they position the joint to keep their dot right inside the maze. Now you can see on the torque at the bottom, I have it set to be 30% heavier in the eccentric mode. So it's 10 pounds when he's raising his arm up, but it's 13 pounds when he's coming down. Not only does that make it more challenging from a strength standpoint, that's going to give almost like a quick stretch reflex as he changes directions. It increases it. So it's really going to help to stimulate the neuromuscular adaptations that we're going to need for plyometric activity later on in the rehab. Not only is this a great way to work on strengthening, these programs or applications, they take 30 seconds to a minute. So it's really good for working on muscular endurance as well. And they're a lot of fun. So the patients really look forward to doing these at the end of their session. The next one is called interactive line, and it's very similar to what you saw with interactive path. Now you're going to have a series of lines that pass through the screen, and the patient's going to control two dots, and their job is to keep the line right in the middle of those two dots. Now I have Bradley on a pretty simple path here. It's very predictable. It just goes up and down in each rep. His range of motion is getting less. I have written some of these protocols that are much more complex and much more challenging for the patient, but this one's pretty simple here. So next, I'm going to show you a couple games, and the first one is Pong. In this, Bradley's going to control the paddle on the left by moving his knee through flexion and extension. The computer controls the paddle on the right. Bradley's job is to not let the ball get past his paddle. Each time he reflects it, I actually have it set to accelerate and get faster. If your patient's early in the process and you just want to work on positioning, proprioception, you can do this without any external load, or you can load this up as they get stronger. Because these typically tend to go on for 30 seconds, a minute on end, I usually don't set it to be extremely heavy. This is a great one to work on muscle endurance and not just pure strength. This next one's called Breakout. It's almost the same thing, except for now they're going to control a paddle across the bottom of the screen. Their job is to rebound the ball and break the bricks. Just like with Pong, it's really good for muscle endurance. Our patient here was dealing with Achilles tendinopathy, and we just ran him through a few eccentric isokinetic sets, and we're doing this at the end just to really work on that muscle endurance. It's a lot more fun than doing a simple calf raise. So again, these are really good for working on strength, endurance, neuromuscular control. So the last isotonic application is the one that I actually use the most, and it's for power training. So in it, I have it set for a certain amount of torque. I tell that patient I want you to do the concentric as hard and as fast as you can, and then just control it slowly coming down in the eccentric. So it's really good for working that concentric rate of force production. So it's going to help improve the person's power and really help them to get back to those sport-specific activities, loading the muscle with the high intensity, loading the joint with the high intensity.
Thank you again for watching this lecture. To recap, we discussed the science behind isokinetic dynamometer training. We discussed the need for testing. We demonstrated various testing approaches, and we demonstrated various interventions that can be performed with the dynamometer.